timely, and I'm glad, you know, we were able to include this piece in our work today. So thank you so much.
Thank you.
With that, I'm gonna do our transition period here. Just want to remind folks to stick around for the next panel presentation as we shift our poster presenters out and our panelists into our panel to present. We'd also invite you to stick around until 1 p.m. when we announce the bronze winners for our poster session awards. These poster sessions will run 3 times this week, different ones each time. So if you've seen poster presenters today, you'll see different poster presenters at the other poster presentations throughout the week. And there are awards associated with these. So we have bronze, silver, and gold awards for the posters. And we encourage you to stick around to hear about our bronze winners today. Right now, we'll just take another minute or two to make sure we get the next session queued up to begin at noon. We have just about 2 minutes. So please hang tight, and we'll continue in just a moment. Okay, I'm going to do some of our usual announcements here as we transition in case we have some new folks who were not in at the beginning. Just a couple of quick reminders. We do have CE credits available for physicians and nurses. There are some housekeeping items that we need to do if you want to obtain CE credits. You need to ensure that you're signed in with the name you used for registration. And to manage CEs, it's critically important that each individual register themselves. So if you've registered and you want to invite folks to participate in other parts of the sessions throughout the week, don't forward your webinar link, forward the link for them to register so that they can register and get CEs if they're interested. If you are in a room with multiple people, make sure each person registers individually so we can account properly for credits. If for some reason you weren't able to join via the full Zoom experience and you had to dial in with your phone, please make sure that you email your name and phone number that you dialed in from today to Julie Gonzalez at dcha.org. Also, don't forget to complete the post survey, which will be emailed after the summit, which ends on Friday at 1 to the email address that you registered with. I'd also like to remind people this session will be recorded. On-demand sessions will be available via the DCHA website. Place your questions for the presenters in the Q&A throughout the session, and if we have time, we'll queue them up at the end. And as I mentioned in the prior session, you can certainly use the chat feature to interact with your colleagues and with the panelists after the presentation. With that, we'll move right into our presentation session today. I want to welcome everyone to the second day of our summit, if you're just joining us. I have the pleasure of introducing our next session, where you will hear how your colleagues have identified unique challenges to care coordination in their space and how they're working to remove unnecessary roadblocks and to enable caregivers across the continuum to meet the needs of their patients' healthcare needs. This panel will feature presenters including Dr. Ira Rabin, Vice President of Medical Operations and Clinical Resource Management at MedStar Washington Hospital Center, Ryan Bramble, Executive Director at CRISP DC, Mustapha, Vice President of Nursing and Clinical Services at Unity Healthcare, Margie Farrar-Simpson, Manager of Ambulatory Clinical Case Management at Children's National Hospital, and Jerome Schorr, Director of Quality Management at AmeriHealth Caritas DC, will actually moderate our panel today. Jerome, I'm happy to turn it over to you.
Hey, Jerome, we can't hear you.
see him clicking on things on his computer, trying to figure out why his microphone is not working. Bear with us for technical issues here for just a moment, folks.
Does he have headphones plugged in somewhere?
No, I can see him talking, but, and it's, Julie, it doesn't look like he's actually on mute. I think it's a technical issue. Tell you what, I'm going to have Julie, if you can text Jerome the phone number, perhaps you can dial in.
How about now?
Oh, we have a winner.
All right, there we go. Yeah, I had to dial in for whatever reason.
Great.
But
Thank you so much.
Appreciate the patience. I think that we all can agree that the most challenging aspect of healthcare is transitions of care. That space in between healthcare settings where the clinical leadership shifts from one provider to another. That could be a transition from the emergency room to an inpatient setting, from inpatient to a skilled nursing facility, from a skilled nursing facility to home and or primary care, or simply from primary care to specialty care. In each of these settings, there's likely a different clinical team advising the patient on next steps and treatment options. Oftentimes, these providers work from different organizations, use different electronic medical records, and have access to different sets of data to inform their decision-making. The coordination of care between these settings and providers is key. Overcoming these challenges is integral to our overall success in improving the health and well-being of the community that we serve. So that brings us to our first topic of discussion. Each of today's panelists brings their own unique vantage point and experience to the table. Love to hear their thoughts and individual perspectives as it relates to care coordination within their individual organizations. Ira, can you kick us off? Oh, you're muted, Ira.
Can you hear me now?
Yep.
Okay, great. Sorry about that. First of all, it's a pleasure and honor to be on this panel, and really happy to be here today, so thank you. I've always used the analogy of a relay race when it comes to care coordination, and that the most vulnerable part of any relay race is handing the baton off. And I think from our perspective, the handing of the baton off to the next level of care is just so multifaceted, and we have multiple moving parts going from the hospital setting to either a rehab or just home or any other outpatient setting or lower level of care. For example, we might have to set up a PT, a visiting nurse. We might have to get an insurance authorization or an insurance upgrade or a pre-certification. We have to get our hospital summary into the right hands and make sure it's thorough and complete. So I think from all this standpoint, there are just so many multiple moving parts that require a doctor, a nurse, social work, engagement with family, engagement with outside providers, engagement with insurance providers. It's really its own world. And, you know, with so many moving parts, there are always a lot of vulnerable moments potentially here. One thing that we have that I think we do really well is what we call our interditional model of care, where our belief is discharge planning starts at admission, and from the beginning of the admission until the patient is gone, and then even after the patient is gone, we have various disciplines engaging with the patient, with the family, and with each other from the outset. So that obviously includes the doctor and the nurse. Often will, obviously social work or case management, sometimes pharmacists, PTOT. I mean, it really takes a village to make sure a patient is safely transitioned to the next level of care, especially at a very complex hospital where we take care of the sickest of the sick. So I think that's, from our perspective, it's the multiple moving parts at once, and that, you can have everything set up perfectly, but if one little thing is not set up or is not confirmed, you can have all the meds set up and the home IV antibiotics and the physical therapy set up, but if a home care order isn't signed, or if it didn't get to the right place, the whole thing can fall through. So it's a big job. It takes a lot of disciplines and a lot of expertise, but luckily with our multiple disciplines working together, I think we have good strategies to address it.
Great points. Thank you. Margie, what are your thoughts?
First, I'd like to say thanks for being a part of this wonderful panel to talk about care coordination today. I have a unique perspective from the ambulatory side of care coordination, although I too have had experience on the inpatient side. So here at Children's, we really strive to provide care coordination really across the continuum, from inpatient to ambulatory. And we here at Children's are fortunate to have an ambulatory case management program. So there are often warm handoffs between the inpatient case manager to the ambulatory case manager to make sure we close those, have all closed loops and make sure things really do fall in place as they were planned at discharge when they really do get home. I would add to that the patients that we follow specifically in the ambulatory space of our ambulatory case management program, again, we work with patients and families that have short-term needs to make sure that information falls into place for them. But we also have the unique opportunity for care coordination across the continuum for children with medical complexity and those with chronic conditions. And so we work with those families on a longer term basis to empower them to learn how to teach them how to coordinate their care, seek out the service, and make sure they're connected to the services that they need. Additionally, in ambulatory case management at Children's National, we have the opportunity to, we have an ambulatory case management documentation platform of which all providers can see a lot of that information truly across the continuum, because we follow them whether they're inpatient or outpatient, where they're home in their communities. You know, here at Children's, we are very focused because it's not just about the patient. It really is about the patient and the family. And so we really strive to look at the total picture for the family, because there's significant needs for other members of the family that will affect the child's needs. Some of those may be medical, but a lot of them are not medical. And so screening for social determinants of health, those kind of things are really important. So we really strive to empower our patients and families, educate them. We'd like to see them graduate from ambulatory case management when they are able to do that, so that we really can best impact their healthcare outcomes, but non-medical needs as well.
Thank you so much. Appreciate that, Margie.
You're welcome.
Ryan, coming from the perspective of the district's HIE, what are your thoughts and what's your perspective?
Yeah, thanks, Jerome. So for us, you know, obviously it's essentially a technology provider and a utility for the movement of health data. Care coordination is really one of the most valuable arenas in which we can make a difference. And even just a little bit of data, if it can be shared through the HIE, can help improve the understanding of a patient's history as they move across the continuum. So for us, we really focus on a few things. When we meet with practices, we don't prioritize, you know, deep technical integration first. We first prioritize just an understanding of their patient population, so that we can add that to our what we call the care team. So if you look in CRISP, you'll see a patient's care team information. So at the very least, you know, a doctor in the ER or a care manager somewhere else, or if a referral has happened, you can see a list of people and organizations that I've touched, and that could be my primary care provider, it could be my case manager, it could be my food insecurity program, it could be you know, diabetes management program somewhere. And so we do try to prioritize that over, you know, deep technical integration. We of course would like to get then the subsequent clinical data and whatnot to further you know, shed light on the patient's clinical history. But you know, the focus on care coordination for us has been a relatively technically easy thing to do and most valuable. So that's the number one thing we do from the HIE perspective. Our job really is to just convene and to connect. You know, we want to bring people together. We want to make it easier for them to understand their shared patients. And so, you know, from my perspective, it's really about just being part of the conversation and connecting the pipes if we need to connect pipes to make those things easier to understand. We don't seek to get in the way of better methods of communication. So if you're in a system and you have a really good way of communicating with providers in your system, we don't get in the way of that. But when you're crossing the systems, that's really where we try and come in make it easier to help coordinate care.
Much appreciated. Thank you so much. Silifat, what are your thoughts?
Good afternoon, everyone. And I too thank you all for letting me be a part of this panel. I think it's very important and I'm honored to be here. From the perspective of Unity Healthcare, being that we are an FQHC, federally qualified health center and the largest one in DC, we take care of the most vulnerable populations within the District of Columbia, including the homeless population. So our outlook on coordination of care relatively streams around providing the best services that we could and incorporating all of their needs at one, kind of like a one-stop shop. So we provide primary care services, social services, mental health services, behavioral health, dentistry, podiatry, several pediatrics, OB, various amounts of services that we provide to our patients. And we utilize the PCMH model, the patient-centered home model, which is a comprehensive care and patient-centered approach, coordinated care, which provides accessibility of services and quality and safe care to all of our patients. From our perspective, and we also utilize our services, and we also partner with a lot of you that are even on the call today. We partner with Children's for our pediatrics patients. We partner with MedStar Washington Hospital Center. A lot of our patients are there and referred there for certain services. We utilize CRIS and the MCOs as well. So for us, I'm looking on the ambulatory side, but also the vulnerable population side, we try to incorporate as many services as we can for our patients, regardless of insurance, the ability to pay or not be able to pay. And we have all the services that we could provide to them, hopefully getting them to where they need to be. We have a My Health GPS federally funded program as well, in which we utilize pre-visit planning and provide services for them. We partner with DCPCA, Department of Healthcare Finance, HRSA. So we have a lot of stakeholders involved as well, and trying to navigate that and coordinate all of that for our patients is essential. We provide walk-in services and coordinate everything that comes up, with COVID, with the tents, flu season being upon us, having to coordinate all of those services as much as possible to our patients and to the public as well.
Thank you so much. It's interesting to hear that from each of our different perspectives, the different ways we define and look at care coordination, but something that resonates throughout is how important it is. And when successful, how impactful that coordination across all of our different settings is for the patient. I'd like to shift gears for just a second and switch over to the challenges we face in this space and what challenges each of your organizations have as it relates to care coordination. I know, coming from the managed care perspective, this is an area we are heavily vested in and want to see successful because we recognize the import, but it's often difficult to identify where the challenges lie when we're not in the room where the decision is made. So when you find out after the fact that there's a need or coordination or assistance that needs help or our programs could facilitate, it's a bigger challenge. So I guess that communication piece offers a bit of a roadblock. But I'd like to hear more about each of your organizations and the challenges that you've seen in your experience over the years as it relates to care coordination. Margie, do you want to go ahead and start this topic up for us?
Sure, I will, Jerome. I'm sure a lot of the challenges we'll find that we all share, but I would say just kind of listing some of the challenges that we see. First is, of course, there's a lot more prior authorization than there used to be, whether it's for medications or services. And so sometimes that timeliness of those kind of alters things a little bit. But there is definitely a lot more prior authorizations that we see. Really unique to our vulnerable population here, especially those that are stretcher bound, is medical transport, whether it's discharged to home, or even more significant from my ambulatory view is medical transport for those patients coming in for clinic visits. They do get here and get in between appointments. Those kind of things are a bit of a challenge, but we are working with our partners and stakeholders to address those issues, which we are really happy about that. I think for a lot of families and children's families too, having a coordinating care and having all the providers, because most of our patients have multiple subspecialists, have the same information and knowledge and work from one care plan. So that coordination and facilitation of communication, I think, is always going to be a challenge, but it's definitely improving because again, many of our kids have multiple specialists, and so we rise to that challenge often, though, by having patient care conferences specifically and inviting those providers to be a part of that conversation. And of course, for those families, getting different information from different providers is very confusing for them. And so we, as case managers here at Children's, help to bring more clarity and more understanding among all of the team members around that child's plan of care. I would say also having folks, it's much better to renew, specifically those that have Medicaid, because we know our families have multiple stressors in their lives and maybe transit at time and really forget. So we try to work specifically on the ambulatory side of those patients in our caseloads to help them plan ahead to make sure that that happens. And I'll just add one other area that's specific, again, on the inpatient, on the ambulatory side, is transition of patients to adult care, especially for those with multiple conditions, multiple chronic conditions. That can be a bit of a challenge, but we are working to streamline our process to begin those transition conversations when the patient is at 16 years of age, and working with the patient and the family to help them to transition, to begin to think differently over time and empower them to take on more of their care. Our challenge sometimes, though, is finding providers for those technology-dependent children in the community, in the adult world. But we're trying to move forward with that also.
Awesome. Silifat, how does that resonate with what you're seeing at Unity?
As far as our challenges with Unity, a lot of our challenges come from resources and being able to make appointments, coupled with the fact with the pandemic that is going on and trying to coordinate still providing services but having social distancing. We have many families who come that have multiple children, and with schools not being fully open yet or daycares not being fully open, they have to bring them to some of the appointments, but it becomes a challenge when they, waiting in the waiting room or needing follow-up labs. So we try to incorporate different things as far as providing a different kind of access. We've added access as well, meaning that we've extended some hours at our sites and have separate visits for labs, maybe only if they're getting telemedicine visits. So we do have telemedicine visits, which is about 50-50 or 40-60, depending on the needs of the patient, if it's primary care or if it's a specialty concern. We have challenges that include, patient associates and staff, that have issues with, childcare, and also being able to be amendable, to have flexibility to change their hours, to be able to service the patients. We do the best that we can, and we work with a large variety of patients. Our visits are monthly, are about anywhere from 30 to 33, 35,000 visits a month throughout all of our centers. So it can be quite a challenge trying to make sure that we get everybody in as much as we can. However, the challenges still exist. We have decreased the no-show, which is good because they're able to now utilize audio or telehealth visits for most of their needs. Challenges also include getting our little ones in to now restart and get their immunizations and vaccines that they needed before, but was kind of set aside because of the pandemic, obviously. However, we are trying to, getting back on track. The only other challenges we see is possibly dipping down a little bit, hopefully not, but with the impending flu. So we're trying to promote everyone to, get their flu vaccines, and we offer times where patients can come in separately, in addition to regular visits where everyone is offered a flu shot. And so we have separate setups for that as well. But, the weather coming, impending winter, with our tents, separating that out, that's probably an impending challenge that will be coming up when we want to do the COVID-only visits in the tents, depending on the weather, if it snows, and if the heaters will suffice our tents that are outside of our larger practices, then we would have to move them inside. So lots of things to think about, lots of things to try to get ahead of. However, those are foreseen challenges that we see coming down the pike. PPE hasn't been an issue so far, so we're able to, thankfully, accommodate staff and patients in that sense as well.
Thank you. Ira, shifting over to the inpatient setting, what are you seeing in your space?
Sure. I mean, I'm going to echo a little bit what Margie was saying earlier. I think that the issues like with pre-authorizations and sort of just paperwork and bureaucracy are certainly a challenge on the inpatient side as well. I think also one of the things that we see here, just because we have such a large patient population, we're obviously the largest hospital in the district, and also we treat a very at-risk and vulnerable population as well, that there are limited resources from, let's say, a behavioral health standpoint or outpatient substance abuse resources. So sometimes there's limited availability to get folks the help that they need kind of long term. I'd say also that taking into account the social determinants of health as well, we can be great with getting all the medications correct and setting up the appointments, but if someone has to make that awful decision between affording their medications or putting food on the table, that's a very difficult decision to make, and that hampers good care coordination upon discharge. We can set up all the appointments or get an outpatient hemodialysis chair for someone, but if they don't have transportation back and forth, not just for 1 or 2 visits, but chronically, that becomes a very, very difficult and unsustainable situation as well. I'd say another unique challenge that we have here at the hospital centers, that being a referral center, especially for complex cardiac cases, neurosurgical cases, burn cases, we get patients from all over. We serve the district, and we're proud to serve the district, but we also get several patients from, all over the country. We often will have patients from West Virginia, Pennsylvania, and trying to coordinate care to a lot of areas outside of the immediate jurisdiction, which has different rules and different regulations, and makes transport and all those other things I just mentioned all that much more challenging. And just from a logistical standpoint, really you can create some issues sometimes. I think overall, just panning out to the 30,000 foot view, if you will, I think the big challenge for any healthcare organization, inpatient, outpatient, is we need to transition our thought about care coordination from the episodic to the continuum of care. And I think in the inpatient acute side, hospitals in general are always focused on the acute episode and the acute admission, and that's great, and that's that's what's first and foremost in front of us. But I think the big challenge going forward through 2021, through the rest of the pandemic, beyond the pandemic, is to really start thinking about care as a continuum. the longitudinal aspect of care, including the social determinants, including making sure not just one visit is secured or 1 week of meds is secured, but that we've set the patient up for long-term success.
Oh, it's an excellent point. And speaking of that continuum of care and the sharing of data across settings, I mean, that's an area where your organization, Ryan, plays a key role for us here in the district. Can you speak to the challenges from your perspective?
Yeah, sure. So the major challenge we face is one around kind of data quality and data standardization, and making sure that everybody is communicating to us in a way that we can translate and normalize. And we've been working very hard to improve the quality and consistency of data that flows through the HIE. At the beginning, we were really just set on getting data in. Any additional data is better than nothing. But as we've evolved, we're really trying to move into a place where folks can really rely on a structured and close to real-time flow of information that's standard across sites, so that if I've gone to 4 different sites with 4 different EHRs and maybe a 5th site that doesn't even have an EHR but submits spreadsheets, that folks on the far end can expect the same thing every time they log into CRISP. They can expect certain discharge data from all of the participants, all of the hospitals in CRISP, and it'll be there every time. And that's really where we're trying to move. And so the challenge has been moving in that direction. There's standards for these things, but they're not all widely adopted. As we move into exchanging social data, social determinants of health data, through our partnership with DCHA and the Corey project, the standards are even less mature there than they are in the sort of traditional health data exchange world. And while there's been some great movement with folks like the Gravity Project who are kind of coding all of these things and getting these codes set up, it's not perfect yet, and a lot of things are different. And so for us, the challenge is making sure we can kind of be the Rosetta Stone for all those different nomenclatures, and so that on the other end you can translate what it looks consistent. And the other thing is probably just communication, making sure our users know what to expect when they get into CRISP. They know what to expect when they participate and share data with CRISP. And making sure people are aware of the things we have, or that we are transmitting care team information, that we are getting into social determinants, and that they can really expect more of those things as time goes along.
Thank you. No, that's good. I want to shift just a little bit to talk about COVID-19. I mean, that is in the forefront of every news cycle and definitely impactful in the healthcare space. And just, explore a little bit how that has affected us, how it's impacted our healthcare for the positive or for the negative. I know, although there have been challenges, I've been really optimistic about the innovations and the responses that we've seen in this space that hopefully we'll be able to continue afterwards, whether it be the increased partnerships between provider groups, the increased utilization and advancement of telehealth options, and just the redefining of care and finding new ways to ensure that we meet those needs for our community. Ira, if you could kick us off in that area, just talking a bit about what you've seen as it relates to COVID in this space.
Sure. I mean, I'll start, I'm a positive guy, so I'll start with positives. I think to one point you just sort of touched on, telehealth has been a big positive. Telehealth has always been something that's out there. It's just technology. It's slowly coming on board. Some people are using it, some people not. I think COVID has forced us to use it more, both clinically and when engaging with families. And I think what was a little bit scary and a little bit unknown from the telehealth standpoint has been a success for the most part. And I think now it's going to be a modality that's here to stay. And so I think that's something in a sense to celebrate, especially when we think about continuum of care and all the things we've already talked about. People with difficulty with transportation or following up with the doctor, if we now can do that successfully and more smoothly through telehealth, all the better. So I think that's certainly one success and one positive. I think I think another positive that we've seen, at least from the hospital center standpoint, is just how everyone came together to always do what's best for the patient. I mean, we've had people to sort of literally show up when this was evolving, saying, "What can I do? How can I help?" I think that we also saw just people in the city, not just the hospital center, but people in the city at their best, whether it was coordinating for potential alternative care sites, whether it was clinicians talking together about what successes we're seeing from an intervention standpoint and a therapeutic standpoint. I've really never seen the entire medical community and really the city as a whole come together as one to help the population. I think the energy around it was great, even with as uncertain as it was, and even as scary as it was, and there's still an element of uncertainty. But I think that can-do attitude, we're going to do whatever we can and whatever it takes to help our patients, has been it's been very inspiring. I'd say some of the negative things that we've seen is especially from a care coordination standpoint, has been the difficulty in transitioning patients to the next level of care. Especially during the height of the pandemic, it was almost impossible to get patients to nursing homes, rehab facilities, lower levels of care. And understandably so. I mean, we knew of all the breakouts that were occurring at these facilities, and we certainly didn't want to contribute to them. And we understand that they needed to control those environments as well, and make sure that safety was paramount there. So that's certainly understandable, but at the same time, it made it difficult to get patients who needed rehab, who needed the next level of care, to that next level of care. So that was certainly one negative impact. I'd say the other one is visitation. And the lack of visitation. I know people have touched on it throughout some of these other panels before us and a little bit here, but I think we think of visitation as just it's a negative satisfier for patients or families, but I think it goes beyond that. I think during the height of the pandemic, when a loved one is not doing well or potentially passing away, and someone couldn't physically be there, a family member couldn't physically be there. I mean, that was very tough, obviously for the patient and family, but it was also tough on the staff to be able to just have to experience that. But also just when engaging with family members about safe discharge plans, safe care coordination, trust is so important. Getting at eye level with folks, having that face-to-face conversation is really important to establishing that trust, especially on the inpatient side, where there's often not a longitudinal relationship with the providers. So if with the lack of visitation, being forced to have that initial and continuous relationship with the family members over a medium and not live, I think was very challenging. And it certainly took an impact on patients and families, but also on staff. I think it did hurt morale a little bit. And in general, I think one of the things we like to think we're in control. We like to have certainty in medicine. And certainly just in general, the uncertainty about COVID was a negative at first, especially during the height of the pandemic. I think we've come through it pretty well. We're learning more and more every day. We're getting more optimistic every day. But at the time, it was certainly a challenge.
Ryan, as that key connector, how has it affected your operations?
Yeah, so we haven't had a lot on the negative side. Obviously, we don't deal with patients directly, so we're not seeing a lot of the sort of really serious negative consequences of the pandemic that the other folks on the call will see. For us, it did cause us to have to delay a few projects as we moved getting connected up with the COVID data as a priority. And this, the staff is not able to be out meeting with providers and understanding their needs a little better, like we like to do, have our outreach folks out there really trying to understand workflows and such to deliver better products. But the team has transitioned to virtual work very easily. It's something a technology company can do pretty easily. So, I've been surprised in my own interactions with the team. And then also when I've had to do some telehealth visits with doctors, how great the infrastructures are working. The video infrastructures are, never been tested like this. And they seem to be working for the most part pretty well if you have access to those things, which of course, not everybody does. Though on the positive side, there's been a number of positives. We have been fortunate in that it's really strengthened our relationship with public health and as a public health utility. I think the pandemic really accelerated kind of in the direction we were going, where we were starting to build connections with public health and getting more public health data in the HIE, but the pandemic just like bulldozed through all the barriers. And, we were immediately getting the COVID data. We're now sharing the COVID data with patients' care teams as those come in every night. We get the positive file from DC Health and we alert everyone on the care team that their patient is tested positive. We're doing some really interesting work with DC's public schools around absenteeism and health impacts of absenteeism, and that's being now transitioned into virtual absenteeism. which I think could be very interesting. A pilot project that we're doing in partnership with them and pediatricians over at Children's. And so there have been a number of unique use cases that I think are going to be long lasting. And I think that hopefully folks are seeing the value of a really district managed public health utility where we have such great shared governance that, you know, for the next problem, the next pandemic, God forbid, you know, we can move quickly and we can move in the best interests of our participants here in the district to really make sure that all of the connections are in place. And as we move into next year and you know, vaccines and flu getting mixed into the mix here, we hope that we can be a little bit of a broader light on the data that a patient might have and hopefully assist in what's going to be probably a very busy couple of months for providers.
Very true. Thank you. And those reports and tools have been invaluable. Silifat, you spoke a little bit earlier about the tents and the telemedicine and things in that space. Can you expand more about how COVID has affected you there at Unity?
Sure. So COVID has affected us, like I mentioned previously, and I'll follow Dr. Rabin's way with pointing out the goods first. So of course, telemedicine was a godsend for us, being that we're an ambulatory outpatient services organization, so which in turn increased access to care for our patients. They were able to utilize those services in order to be able to still be seen in light of the pandemic. We were also able to, we received several donations from various organizations for PPE, you know, when we were not able to acquire them as easily as we could in order to be able to open up the tents and have people in PPE all day, you know, screening patients for COVID. So that was, you know, that was a great big help for us. We were also able to purchase and procure some, but not knowing what the burn rate was at the time, at the beginning of the pandemic, getting those PPE donations was absolutely essential. It increased our communication on the leadership level too, as far as determining, you know, where our largest needs were, where our biggest, you know, patient visits were, so that we can acquire tents. We were able to get tents and sometimes 2 tents at some of our sites. And then with collaboration with the Department of Health, Human Services, you know, we service the homeless population. We have about 11 homeless sites, but we also needed to be able to pull those from off the street in order to be able to protect them and protect the public as well. You know, so Department of Human Services assisted us with opening up about 6 hotels in DC and converting them into sites for homeless that were strictly for those who tested positive for COVID, and then those who had chronic illnesses and were more vulnerable to having COVID, and they're still open to this day. So we, and then they also were able to service people who needed to be able to quarantine for 14 days post-discharge, or, you know, if they had symptoms or tested positive and had no symptoms and couldn't stay at home. Because of the population that we serve, there's usually multi-generational people living in the household, and in order to quarantine, we were able to have some space for them in order to be able to rule themselves out in quarantine, so that they wouldn't, you know, increase the spread. Some of the, you know, on the downside, we had lots of, you know, we had some loss. We did lose some associates and patients that lost family members due to COVID. So it was really tough. Making accommodations for patients with social distancing, you know, was a challenge and has been a challenge. Providing mental health services for people that have to deal with the loss and cope with the loss, you know, as well as our MAT services, you know, for patients who have substance abuse has been a challenge. And then the confusion and always upgrading and updating or looking to the CDC recommendation for, you know, what we're supposed to do. And, you know, things that come into light and things that were, miscommunicated. So, the public hearing one thing and then we putting out another thing. So having to coordinate that and always updating and send the message out through various forms of communication to our patients, to our staff, to families, to our board, was very essential, but it was challenging at some time. So those are some of the things that, we continue to deal with and continue to modify and as we go along.
Thank you. Margie, I know from Children's you probably have some similar challenges and would like to hear more about how that's affected your operations there.
Yes, Jerome. We're thankful that children weren't as impacted as adults, but children were impacted. We too have Unity, shared. We too have been very active with a significant ramp up in telehealth so that we still have access available for patients and families. And that really, as we shared earlier, is a modality I'm sure is here to stay for all of our specialists and primary care. I would say that it's not necessarily a positive, but it was Children's National that was first to recognize the Miss C kind of syndrome in children. And so I think that was really significant for all of us to know that children really can be affected, although these are the kids that were kind of post-COVID that had the syndrome that was really significant to their sequela to their lives. And so we continue to do a lot of research and do see some of those patients here at Children's. Like other facilities, volume definitely decreased significantly initially when COVID occurred. But as shared, we have been doing a lot of work around telehealth and continue to see some patients on site with all of the appropriate manifestations put in place around social distancing and PPE. We have been fairly successful with not having issues related to PPE here at Children's. Communication is, in my opinion, quite excellent among leadership with all of the members, all of the staff here at Children's around where we are as it relates to COVID, whether it's on the patient level with transmission and or frequency of number of patients that we're seeing, or employees that may be have been infected or affected, all of which have been really low for us. So we're really thankful for those major positives. But again, I think just that ongoing communication from leadership down to everyone about where we are with COVID-19 has been quite excellent. As at Unity, many families have missed their patients, their children have missed immunizations because one, they were afraid to come. That is turning around some. Children's did activate our mobile van to do some immunizations in the community, but we continue to bring patients in and have prioritized those ages of when immunizations are most important, which are usually the first couple of years. I would say specifically for our families, which what we feel the most as it relates to COVID, one is just about educating them what the guidelines are and masking and the importance of it, but seeing the effects around their mental health, families, patients too, identifying social terms of health that have really affected them, whether it's food insecurity, which we definitely have seen a lot, individuals losing jobs. Significant for our children too is remote learning. The district has done well with trying to support patients and families around that, but that was quite a ramp up to make sure everybody had the tools that they needed and hotspots if they didn't have Wi-Fi, those kinds of things. And so it's been a challenge, but everyone's in together to identify what the issues are and to mitigate as much as we can and to have an open dialogue and allow patients and families to just talk, because a lot of times that's what they really need. They need someone that can listen to them. So we are rising to the challenges, and we look forward to when there's less of a need around, specifically around COVID-19, but we know that still continues.
Great. Wow. So at each of these perspectives of the conversation, I think as what has been shared is overlapped and aligned, I think we hear over and over and over again that continued or that universal commitment to, I think what Dr. Rabin said best, the complete continuum of care, not just specific episodes or incidents, and looking at the whole person, addressing those social determinants whenever we can, because you can't focus on health if the other elements of your life are in the forefront. I'd really like to close this up with identifying some of those successes we've seen, both so we can share amongst ourselves and share with the group where we've seen the greatest successes in this space as we've leaned on each other and between the various spaces that we each work. Ryan, given that your organization is a key part of our overarching success in between sharing of data, I'd like to start with you on some of the successes you've seen and maybe best use cases or whatnot.
Sure. So, we hear about our successes mostly anecdotally, and we love to hear about them when they exist. I think from this perspective, we do measure utilization, and those are sort of the things that we get graded on as staff and such, as far as using CRISP. But the successes are not really for us about more people using CRISP. It's more about the outcomes, and those are harder to measure. And so when we hear the anecdotes of patient was in the ER and CRISP said they had a care manager, and so we called the care manager and we were able to avoid an admission. And we hear that from time to time, and that for us is really the number one success we can have in the hospital setting, is that we've shed light on something for a patient that would otherwise potentially be admitted, potentially go under tests they wouldn't necessarily have gone under, that there be medications shared in that coordination that are helpful to know about. And so that's always been our kind of biggest success. We've had success as well in some of the more acute alerting capabilities. So if we're able to, if we know that a patient has had a prior opioid overdose event and we're able to communicate that to the emergency department, and it may prevent them from administering drugs they don't want to administer to a patient like that. And so we've heard successes around those things. And so really for me, what it gets down to is it always is usually kind of this really simple thing that can drive most of the success. It's not necessarily getting the longitudinal patient record into CRISP that's 40 pages long. And it's really about how do we sift through to the most important elements and getting those kind of pulled out simply and made alerted right in the system. So we've recently deployed our embedded application into more electronic health records. So if you're using Epic or Cerner or Athena, you don't have to go log into CRISP. It can just appear in your EHR. We're very close finally with point-click care and eClinicalWorks, which will be huge for the long-term care community and then the FQHC community, where we can just get rid of all of those logins and it can just load up in the side if it needs to. And so for us, it is our lesson learned over the years has been just stay out of the way and show the data when you have it. And our goal really would be that in the end, you may not know you're even using CRISP to see the data. It's just there. And we're really helping to kind of connect the things, just like you don't know that you don't think about the fact that you're using the power lines to operate your computer to see data. It's just kind of moving across the power lines. So that's really when we see we've had the most success.
Nice. Actually, I want to jump back to you, Margie, on that topic too. Where you've seen the biggest successes?
So as I think about successes at Children's around care coordination generally or generically, it really is, we really are focusing on care truly across the continuum, inpatient, outpatient, in their community. And we see the difference that it really makes. So specifically for the ambulatory case management program, even if the child was inpatient and there was a warm handout to ambulatory, We work with the patient and family to screen for social terms of health that we know are very significant for our patients and families. We create a patient-centered care plan with the family, and that's where they identify what they want to work on. Because really, if you get that buy-in, you build a really good and trusting relationship, which is really significant to improving healthcare outcomes, because they'll listen to you. I would also share that some of our other kind of best practices that we've had that I think that have majorly helped us with care coordination is really building a strong partnership or collaboration with our payers. As an example, we have a monthly meeting with HSCSN leadership around patient care coordination. And so we talk about specific patients, we all share our perspectives and come up with a plan. And it really, really does work well because we're all in this together and working for the same cause of the patient and family. Specific to the MyHealth GPS program here at Children's, which is the free benefit program for individuals that have 3 or more chronic conditions, we too have monthly to quarterly meetings with each of the managed care organizations, which really adds a lot of value. And so that partnership really improves care for our patients and families. And I think I would just end with two short stories. One is about a patient who was 18 years old in MyHealth GPS with 3 chronic conditions, one being autism. And we helped this family, he had obesity also as one of his conditions. We helped this family and patient to enroll in a cooking class over the last summer. And this young man enjoyed cooking, so we knew what he'd like or what his strength was. He learned how to cook differently for he and his mom, and he lost over 15 pounds over a summer. I mean, so we can celebrate with him that major change in his life. His medical team was thrilled to see that happened. And the other example that I will share is a 9-year-old who had persistent asthma with other, also had reflux and a history of congenital heart. And this young man was seen in the ED multiple times, transported through EMS. Several admissions, and this young man is, so we're excited about the attendance that will be available in CRISP. This young man missed 80 days of school, 9 years old, because of his asthma. And so we got together a patient care conference for this young man with his primary care provider, school services, case managers, the members of MyHealth GPS, pulmonologists, and everybody got to share kind of their perspective of what they knew, which really created a lot more shared knowledge and information. And we were able to put together a plan with what the issues were for this family to better support this child and his mom, of which they also had some mental health needs. And this young man, as we shared the plan with the mom, she was quite excited. And the following school year, this young man barely missed 3 days of school. So the power is great in what we can do when we all have a shared care plan.
Wow, those are great stories. Pushing up on time, Silifat, do you have any thoughts?
Sure, I would just like to point out pretty much lots of what Margie said from Children's, because we clearly are involved in a lot of the same programs, including MyHealth GPS. And we also, our CMO is actually a pediatric pulmonologist. So we are also involved in the Children's Nationals asthma program for our children as well. So, you know, the good things and the pluses that have come out for us is that, you know, we have more access to care for our patients using the telemedicine, and we're able to separate out, you know, our patients who are more vulnerable in order to keep everyone safe as a whole. And we, you know, we're still focused on the patient-centered medical home framework where we, still are able to provide a holistic array of services for our patients without too much of a stop. Our visits are still up, which is great for us. And, we are happy to that we still have our stakeholders who are heavily involved in providing and partnering us with providing care for our patients. So getting all of those services and providing everything that the patient needs as much as possible and on the continuum, utilizing My Health GPS and our framework model to provide them with care has really been an essential part of, or anything that, good has come out of, in light of the pandemic, I should say.
Thank you very much. Dr. Rabin, I'm giving you a chance to bring us home as you will close it out. And then if I can ask the panelists to refer to the chat, and we'll try to answer those questions in the chat since we'll be butting up against the next session.
Sure.
Ira?
Sure, great, thanks. So I think very briefly, I think we forged some really good relationships with several DC entities on the insurance side, on the at lower levels of care. So we've really great communication. I think those have been very successful. So we can troubleshoot any acute issue that pops up better than we could have, let's say, 5-7 years ago. I'd say the other thing is the major success is we have now a lot of proactive providers and clinicians who I think see themselves not only just as healers and healthcare providers, but healthcare educators. If we think of ourselves as a good care coordination, taking a holistic approach to care coordination, not just the clinical care holistic approach, but more a holistic approach to care coordination, we start to see ourselves as not just clinicians and healthcare providers, but healthcare educators. So this is where we can address things like health literacy, especially for the vulnerable populations. And I think we're starting to do that, whether it's discussion of cost of meds, or why their body needs a certain medication, or why they need to see a certain doctor. I think that's how we really win the battle of good care coordination, by really getting down, by really looking at this from the big picture perspective.
All right. Thank you so much. Gail, I will hand it back to you. Thank you for the opportunity today.
Sure. Thank you so much, Jerome, Silifat, Margie, Ira, and Brian. What a great opportunity to hear from so many different perspectives on this topic. We really appreciate you sharing your insights today. As Jerome mentioned, our DCHA team will post the audience questions in chat so that our panel